Today we will see about diseases of cornea. Anatomy and physiology. Cornea is a transparent avascular watch glass-like structure. It forms anterior 1/6 of the outer fibrous coat of eyeball. Dimensions. Anterior surface of cornea is elliptical with an average horizontal diameter 11.7 cm. Posterior surface of cornea is circular with average diameter of 11.5 mm. Thickness of cornea in the centers varies from 0.5 to 0.6 mm, while at periphery it varies from 1 to 1.2 mm. Radius of curvature. The central 5 mm area of the cornea forms the powerful refracting surface of the eye. Anterior and posterior radii of curvature of the central part of cornea are 7.8 and 6.5 mm. Refractive index of cornea is 1.376. Refractive power of cornea is about 45 diopters, which is roughly 3/4 of the total refractive power of the eye. Histology. The cornea consists of 6 layers from anterior to posterior. These are epithelial, Bowman's membrane, substantia propria, Debridement membrane, which is also known as Dewars layer. Debridement membrane and Endothelium is shown in the diagram of 6.1. We will see in the future. Epithelium. It is of stratified squamous epithelium type, becomes continuous with the epithelium of bulbar conjunctiva at the limbus. It consists of 5 to 6 layers of cells. The deepest layer is made up of columnar cells. Next, 2 to 3 layers of wing or umbrella cells, and most superficially 2 layers are made of flattened cells. Tight junctions are present between superficial epithelial cells, prevent penetration of tear fluid into stroma. Limbal epithelium. The basal epithelial cells of the limbal area constitute the limbal stem cells, which amplify, proliferate, and differentiate to corneal epithelium. Microscopic structure of cornea. Endothelium, Debridement membrane, Dewars layer, stroma, Bowman's membrane, and epithelium. Epithelium, Bowman's membrane, stroma, Dewars layer, Debridement membrane, endothelium. Damage to this area results in invasion of conjunctival epithelium on the cornea to the limbal layer. Bowman's membrane. This layer consists of acellular mass of condensed collagen fibrils. Bowman's membrane. It is about 12 micrometer in thickness and binds the corneal stroma anteriorly with basement membrane of epithelium. It is not a true elastic membrane but simply a condensed superficial part of stroma. It shows considerable resistance to infection, but once destroyed it is unable to regenerate and therefore yields by scarring. Stroma. Substantia propria. This layer is about 0.5 mm in thickness and constitute most of the cornea. 90% of total thickness. It consists of collagen fibrils type 1, type 5 fibril and intertwined with filaments of type 4 collagen embedded in hydrated matrix of proteoglycan. The lamella are arranged in many layers. Proteoglycans are chondroitin sulfate and creatine sulfate. The lamella are arranged in many layers. In each layer, they are not only parallel to each other but also to corneal plane and becomes continuous with scleral lamella at limbus. The alternating layers of lamella are at right angle to each other. Among the lamella are present keratocytes, wandering macrophages, histiocytes, and few leukocytes. Pre-Debridement membrane Dewars layer. It's discovered by Harminder Dua, Indian scientist, Indian ophthalmologist, located anterior to Debridement membrane. It is about 15 micrometer thick acellular structure. It's very strong and impervious to air. Debridement membrane. Debridement membrane is strong homogeneous basement membrane of corneal endothelium, which is separated from stroma pre-Debridement membrane. By pre-Debridement membrane, it is very resistant to chemical agents, trauma, pathological process. Therefore, Debridement can maintain the integrity of eyeball for long. Debridement membrane consists of collagen glycoprotein. Unlike Bowman's membrane, it can regenerate. Normally, it remains in a state of tension, and when torn, it remains on the in a state of tension, and when torn, it curls inwards on itself. In the periphery, it appears to end at the anterior limit of trabecular measure as Walby's line. Endothelium. It consists of single layer of flat polygonal, mainly hexagonal epithelial cells. Is named as endothelium. which on slit lamp microscope appears as mosaic. The cell density of endothelium is around 3000 cells per millimeter square. The human endothelium cells do not proliferate in vivo, and cell loss with age is compensated by enlargement, polymegathism. There is considerable function reserved for endothelium. Therefore, corneal decomposition occurs only after more than 75% of the cells are lost. The endothelial cells contain active pump mechanism which keeps cornea dehydrated. Blood supply. Cornea is avascular structure. Small loops derived from anterior ciliary vessels invade its periphery for about 1 mm. Actually, these loops are not in the cornea but in subconjunctival at limbal area, which overlaps the cornea. Nerve supply. Cornea is supplied by anterior ciliary nerve, which are branches of ophthalmic division of fifth cranial nerve. After going about 2 mm in cornea, the nerves lose their myelin sheath and divide dichotomously and form three plexus: the stromal, subepithelial and intraepithelial plexus. Applied physiology. The two primary physiological function of cornea to act as major refractive membrane to protect intraocular contents. Corneal transparency. Peculiar arrangement of corneal lamella. It is a result of peculiar arrangement of corneal lamella lattice theory of Morris. Peculiar refractive index of corneal lamella with variation less than 200 micrometer. Avascularity of cornea. Relative state of dehydration 78% water content, which is maintained by barrier effects of epithelium, endothelium and active Na plus ATPase pump of endothelium. Swelling pressure of the stroma, which counters the inhibition effect of intraocular pressure. Corneal crystallines, that is water soluble proteins of keratocytes. Trans-ketulose and aldehyde dehydrogenase class Ia1 also contribute to corneal transparency at the cellular level. Metabolism of cornea. Most active metabolizing layers of cornea are epithelium and endothelium. The former being 10 times thicker than the latter requires a proportional large supply of metabolic contents. Source of nutrients. Solutes. Glucose and others enter the cornea by either simple diffusion or active transport. Simple diffusion or active transport. Oxygen is derived directly from air through the tear film. This is an active process undertaken by epithelium. Therefore, corneal hypoxia may occur with overwear of contact lenses. Some oxygen may reach the superficial layer of cornea from perilimbal capillaries, especially when eyelids are closed. Deeper corneal layers are through the aqueous humor. Endothelial requires oxygen and glucose for metabolic proper function of Na plus K plus ATPase pump. Like other tissue, the epithelium can metabolize glucose both aerobically and anaerobically into carbon dioxide and water and lactic acid respectively. Thus, under anaerobic condition, lactic acid accumulates in cornea. Respiratory quotient of cornea is 1%. In general anomalies. Megalocornea. Horizontal diameter cornea at birth is about 10 mm. Adult size is about 11.7 mm. But when megalocornea, horizontal diameter cornea adult size are at birth are 13 mm or greater than after 2 years of age. Salient feature. Cornea is usually clear with normal thickness and vision. No salient features. Clear and normal vision. Systemic vision not Marfan syndrome, Ehlers-Danlos Down syndrome. Differential diagnosis. Ophthalmus. It's a congenital glaucoma. In this condition, IOP is raised and the eyeball is enlarged as bowl. The enlarged cornea is usually associated with central or peripheral clouding and decimal tears. Keratoglobus. In this condition, there is thinning and excessive protrusion of cornea, which seems enlarged, but its diameter is usually normal. Microcornea. It's nanophthalmus. Less than diameter, horizontal diameter less than 10 mm. Cornea plana. This is a rare anomaly in which bilaterally cornea is comparatively flat since birth. Cornea plana usually results in marked astigmatic refractive error. Anomalies of corneal transparency. Anterior embryotoxon. It is characterized by congenital broad limbus superiorly. Posterior embryotoxon. It is refers to thickening and anterior displacement Stolby line, which is formed from the decimal membrane. Congenital corneal opacity. Corneal opacity, scarring of corneal stroma, is often an acquired condition but has been reported to occur congenitally in isolation. And also in association with Loewe syndrome, Axenfeld syndrome, etc. Sclerocornea refers to sclera-like cloudy cornea which may be peripheral or diffuse. Dermites usually occur at inferotemporal limbus and are round, dome-shaped and pink to white to yellow in color. Rarely, dermites may involve large area of cornea, the entire limbus and the entire cornea or even interior of the eye. Differential diagnosis of neonatal cloudy cornea, acronym STUMPed, sclerocornea, tear in descendant membrane, ulcer, metabolic conditions, posterior corneal defect, endothelial dystrophy, dermoid, inflammation of cornea, classification. Inflammation of cornea is known as keratitis. The classification, it is difficult to classify and assign a group to each and every case of keratitis. Classification, it is very difficult to classify and assign a group to each and every case of keratitis, as overlapping or concurrent findings tend to obscure the picture. Temporal morphology classification: ulcerative keratitis, corneal ulcer, depending on location, central corneal ulcer, peripheral corneal ulcer. Two types of ulcer depends on purulent corneal ulcer or suppurative corneal ulcer. Non-purulent corneal ulcer, most of viral chlamydia and allergic corneal ulcer, non-suppurative. Suppurative. Depending upon association of hypopion corneal simple corneal ulcer without hypopion, corneal ulcer with hypopion. Depending upon depth of ulcer: superficial corneal ulcer, deep corneal ulcer with impending perforation, perforated corneal ulcer. Depending upon slough formation: non-sloughing, non-ulcerative keratitis, superficial keratitis, diffuse superficial keratitis, superficial punctate keratitis (SPK), deep keratitis, non-suppurative interstitial keratitis, disciform keratitis. Keratitis profunda, sclerosing keratitis, suppurative deep keratitis, central corneal abscess, posterior corneal abscess. Etiology classification: infective keratitis, bacterial keratitis, viral, fungal, chlamydial, protozoal, spirochetal, allergic, flecternal, vernal, atopic, tropic keratitis, exposure, neurotropic, keratomalacia, erythematous ulcer. Keratitis associated with disease of skin mucous membrane. Keratitis associated with systemic collagen vascular disorder. Traumatic keratitis, which may be due to mechanical trauma, chemical trauma, thermal burns, radiation, etc. Idiopathic keratitis: Moorens corneal ulcer, superior limbal keratoconjunctivitis, superficial punctate keratitis of Thygesen. Ulcerative keratitis: corneal ulcer may be defined as discontinuation in normal epithelial surface of cornea associated with necrosis of surrounding corneal tissue. Pathologically, it is characterized by edema and cellular infiltration. Common types of corneal ulcer are described below. Bacterial corneas being the most anterior part of eyeball, the cornea is exposed to atmosphere and hence prone to get infected easily. At the same time, cornea is protected from day-to-day minor infection by normal defense mechanism present in tears in the form of lysozyme, beta-lysine and other protective proteins. Therefore, infected corneals may develop when either local ocular defense mechanism is jeopardized, there is some local ocular disease, or host immune is compromised, or causative organ is very virulent. Etiology: there are two main factors in production of purulent corneal ulcer: damage to corneal epithelium, infection of iridoria. However, following three pathogens can invade the intact corneal epithelium and produce ulceration. Corneal epithelial damage, it is a prerequisite for ulceration. It is prerequisite for most of infecting organ to produce corneal ulceration. It may occur in the following condition: corneal aberration due to small foreign body, misdirected cilia, concretions, trivial trauma, and in contact lens wearers or otherwise, epithelial drying as in cirrhosis and exposure keratitis, necrosis of epithelium as in keratomalacia, desquamation of epithelial cells as a result of corneal edema as in bullous keratopathy, epithelial damage due to tropic changes as in neuroparalytic keratitis. Source of infection include exogenous infection, and most of the types corneal infection arise from exogenous sources like congenital sac, lacrimal sac, infected foreign bodies, infected vegetative material, waterborne or airborne infection from ocular tissue. Owing to direct anatomical continuity, disease of conjunctiva readily spread to corneal epithelium, those of sclera to stroma, and of the uveal tract to endothelium of cornea. Causative organisms, bacteria reported to cause keratitis can be classified: gram positive, gram negative, gram positive cocci, gram negative cocci, gram positive bacilli, gram negative bacilli, staphylococcus aureus, epidermis, pneumonia, Neisseria gonorrhea, Neisseria meningitis, corn-bearing diphtheria, cirrhosis, Bacillus cereus, Propionibacterium acti, Pseudomonas, Enterobacteriaceae, etc. all cause, and gram-positive filamentous bacteria, Actinomyces, Nocardia, Mycobacteria, tuberculosis, non-microbacterial bacteria, common bacteria, Pseudomonas, Streptococcus pneumoniae, Enterobacteriaceae, Neisseria, etc. Pathogenesis and pathology of corneal ulcer. Once the damaged corneal ulcer epithelium is invaded by offending agent, the sequence of pathology changes which occur during development of corneal ulcer can be described into 4 stages. After invading, these are the 4 steps: stage of progressive infiltration, stage of active ulceration, stage of regression, stage of cicatrization. Progressive infiltration, active ulceration, regression, and cicatrization. Terminal course of corneal ulcer depends upon the virulence of infected agent, host defense mechanism, and treatment received. Depending upon the prevalent circumstances, the course of corneal ulcer may take one of the 3 forms. Ulcer may become localized and heal, penetrate deep, leading to corneal perforation, and spread fast to involve the whole cornea as slowing corneal ulcer. Slowing means whole of the cornea. Pathology of localized corneal ulcer. Stage of progressive infiltration. 6.2a. This is stage of progressive infiltration. Active ulceration results from necrosis, slowing of epithelium, Bowman's membrane, and involved stroma. The walls of active ulcer project owing to swelling of lamella by imbibition of fluid and packing of masses of leukocytes between them. This zone of infiltration may extend to a considerable distance both around and beneath the ulcer. At this stage, sides and floor of the ulcer may show grey infiltration and slowing. This stage of active ulcer, there occurs hyperemia of circumcorneal network of vessels, which results into accumulation of purulent exudates of the cornea. There also occurs vascular congestion of iris and ciliary body, and some degree of iritis due to absorption of toxins from ulcer. Exudation into antechamber from vessels of iris and ciliary body may lead to formation of hypopyon. Ulceration may further progress by lateral extension, resulting in diffuse superficial ulceration, or it may progress to deeper penetration of infection leading to descemetocele formation. Possible corneal perforation. When offending organism is highly virulent and host defense mechanism jeopardized, there occurs deeper penetration during stage of active ulceration. Stage of regression. In stage progressive infiltration, it is characterized by infiltration of polymorphonuclear lymphocytes into epithelium from peripheral circulation, supplemented by similar cells from underlying stroma. If the tissue is also affected, subsequent necrosis of involved tissue may occur depending upon virulence of affected organism. Stage of active ulceration. Stage of regression. Regression is induced by natural host defense mechanism, humoral antibody protection, cell-mediated responses. The treatment which augments the normal host response. A line of demarcation develops around the ulcer, which consists of leukocytes that neutralize and eventually phagocytes the offending organism, necrotic cellular debris. The digestion of necrotic material may result in initial enlargement of ulcer. This process may accompanied by superficial vascularization that increases the humoral and cellular immune response. Ulcer now begins to heal. Epithelium starts growing over the edges. Stage of cicatrization. This is stage of cicatrization. In this stage, healing continues by progressive epithelialization, which forms a permanent covering. Beneath the epithelium, fibrous tissue is laid down partly by corneal fibroblasts, partly by endothelial cells of new vessels. Stroma thus thickens and fills in under the epithelium, pushing the epithelial surface anteriorly. The degree of scarring from healing varies. If the ulcer is very superficial and involves epithelium only, it heals without leaving any opacity behind. When ulcer involves Bowman's membrane and few superficial stroma lamellae, the resultant scar is called nebula. macula and leucoma results after healing of ulcers involving up to one third and more than that of cornea stroma, respectively. When Bowman's membrane only involved, it is known as nebula. When macula and leucoma result after healing of ulcer involving up to one third and more than corneal stroma. Macula and leucoma, one third of corneal stroma is affected. Decimatocele, diagrammatic depiction, clinical photography. This is decimatocele. Pathology of perforated corneal ulcer. Perforation of corneal ulcer result occurs when ulcerative process because when ulcerative process deepens and reaches up to descemal membrane, this membrane stuff bulges out as descematocele. At this stage, any exertion on part of patient such as coughing, sneezing, straining of stool will perforate the corneal ulcer. Immediately after perforation, the aqueous escapes and intraocular pressure falls and iris lens diaphragm moves forward. The effects of perforation depends upon the position and size of the perforation. When perforation is small and opposite to iris tissue, it is usually plugged and healed by cicatrization proceeds rapidly. Cicatrized perforated corneals with the prolapse of iris and clinical photography. Other leucoma is commonest and end result after such a cut-off. It's known as other leucoma. When complete of the cornea is all the layers are affected. Pathology of slowing corneal ulcer, formation of anterior staphyloma. When infective agent is highly virulent and or body resistance is very low, the whole cornea slows with exception of an narrow rim at the margin and total prolapse of iris occurs. The iris become inflamed and exudates block the pupil, cover the iris surface, thus a false cornea is formed. Ultimately, these exudates organize and form a thin fibrous layer over which conjunctival or corneal epithelium rapidly grows. Thus, a pseudocornea is formed. Since pseudocornea is thin and cannot withstand the intraocular pressure, so it usually bulges forward. Along with plastered iris tissue, the ectatic cicatric is called anterior staphyloma, which depending upon its extent may either partial or total. The bands of scar tissue on staphyloma vary in breadth and thickness, producing a lobulated surface, often blackened with iris tissue, which resembles a bunch of black grapes. Hence the name staphyloma. Clinical feature. In bacterial infection, the outcome depends upon virulence of organism, its toxins, enzymes, etc. Broad bacterial corneal ulcer may manifest as purulent corneal ulcer without hypopion or hypopion corneal ulcer. Symptoms: pain, foreign body sensation occurs due to mechanical effects of lids, chemical effects of toxin on exposed nerve endings. Watering from eye occur due to reflex hyperlacrimation. Photophobia, intolerance to light results from stimulation of nerve ending. Blurred vision occurs from corneal haze, redness of eyes, etc. Signs: swelling of lids of varying degree is present. Blepharospasm may moderate to severe. Conjunctivitis, chemos and shows congenital hyperemia and ciliary congestion. Corneal ulcer usually starts as an epithelial defect associated with grayish white circumscribed infiltrate. Soon the epithelial defect and infiltrate enlarged and stromal edema develops. A well-established bacterial ulcer is characterized by yellowish white area of ulcer which may be oval or irregular in shape. Margins of ulcer are swollen and overhanging. Floor of the ulcer is covered by necrotic membrane. Stromal edema is present surrounding the ulcer area. Characteristic feature produced by some of the common causative bacteria are as follows: Staphylococcus aureus, Streptococcus pneumoniae, Gram-positive cocci usually produce an oval yellowish white densely opaque ulcer which is surrounded by relatively clear corneal scale. Oval yellowish white dense opaque. Oval yellowish white densely opaque ulcer which is surrounded by relatively clear cornea, surrounded by relatively clear cornea. Pseudomonas species usually produce an irregular sharp ulcer. With with thick greenish mucopura and exudate diffuse liquefied nucleus and semi-opaque ground glass surrounding cornea. Such ulcers are usually associated with hypopyon. Spread very rapidly and may even perforate within 48 to 72 hours respectively. Enterothelium usually produces shallow ulcer with greyish white pleomorphic separation and diffuse stromal opalescence. The endotoxin produced by this gram-negative bacilli may produce ring-shaped corneal infiltrate. Manifested as shallow corneal ulcer with greyish white pleomorphic separation, diffuse stromal opalescence. Anterior chamber may or may not show pus hypopyon. In bacterial corneal ulcers, the hypopyon remains sterile so long as the descendant membrane is intact. Iris may be slightly muddy in color. Pupil may be small due to associated toxin induced by iritis. Intraocular pressure may sometimes be raised. Ring-shaped corneal ulcers seen in Enterobacter E. coli produce Klebsiella corneal ulcer, which is shallow greyish white pleomorphic separation, diffuse stromal opalescence. Hypopyon corneal ulcer. Etiology. Causative organism. It is customary to reserve the term hypopyon corneal ulcer for the characteristic ulcer caused by pneumococcus, and the term corneal ulcer with hypopyon for the ulcers associated with hypopyon due to other organisms such as Staphylococcus, Gonococcus, Moraxella, Pseudomonas pyocynia. The characteristic hypopyon corneal ulcer caused by pneumococcus is called Ulcer serpens. Source of infection for pneumococcal infection is usually chronic dacrocystitis. Factors predisposing to development of hypopyon. Two main factors which predispose development of hypopyon in patient with corneal ulcer are virulence of the infection and resistance of the tissues. Hence, hypopyon are much more common in old debilitated alcoholic subjects. Mechanism of development of hypopyon. Corneal ulcer is often associated with some iritis owing to diffusion of bacterial toxin. When iritis is severe, the outpouring of leukocytes from vessel is so great that these cells gravitate to bottom of the chamber to form hypopyon. Thus, it is important to note that hypopyon is sterile, since the outpouring of polymorphonuclear cells is due to toxins and not due to actual invasion of bacteria. Once the ulcerative process is controlled, the hypopyon is absorbed. Clinical features. Symptoms are same described by bacterial corneal ulcer. However, it is important to note that during initial stage of ulcer serpens, there is remarkable little pain. Signs similar as that of bacterial ulcer. Characteristic features of Ulcer serpens. Ulcer serpens are grayish white or yellowish disc-shaped ulcer occurring near the center of cornea. Ulcer has a tendency to creep over the cornea in serpiginous forms. One edge of ulcer along with ulcer spread shows more infiltration. The other side of ulcer may undergoing simultaneous disarticulation and edges may be covered with fresh epithelium. Violent iridocyclitis is more common associated with definitive hypopyon. Hypopyon increases in size very rapidly and often results in secondary glaucoma. Ulcer spreads rapidly and has a greater tendency for early perforation. Management of hypopyon corneal ulcer is same as for other bacterial corneal ulcer. It occurs in center. Hypopyon corneal ulcer. Special point which need to be considered are secondary glaucoma should be anticipated and treated with 0.5% demolar mercury. Source of infection: chronic dacrocystectomy. If detected, should be treated with dacrocystectomy. Complications of corneal ulcer: toxic iridocyclitis associated with purulent corneal ulcer due to absorption of toxins in the anterior chamber. Secondary glaucoma, it occurs due to fibrinous exudates blocking the angle of anterior chamber. Debridement as well. Some ulcers caused by virulent organisms extend up to debridement membrane, which gives a great resistance, but due Due to the effect of intraocular pressure, it herniates as transparent vesicle called desmodocele or catocele. This is a sign of impending perforation, usually associated with severe pain. Perforation of corneal. Sudden strain due to cough, sneeze, or spasm of orbicular muscle may convert impending perforation into actual perforation. Following perforation, immediately pain is decreased and the patient feels some hot fluid aqueous coming out of a sequel of corneal perforation include prolapse of iris. It occurs immediately following perforation of in a bid to plug it. Subluxation of anterior dislocation of lens may occur due to sudden stretching and rupture of jonules. Anterior capsular cataract. It is formed when lens come in contact with ulcer following perforation in the pupillary area. Corneal fistula. It is formed when perforation in the pupillary area is not plugged by iris and is lined by epithelium, which gives way repeatedly. There occurs continuous leak of aqueous through fistula. Purulent uveitis, endophthalmitis, or even panophthalmitis may develop due to spread of intraocular infection. Intraocular hemorrhage in the form of either vitreous hemorrhage or expulsive choroidal hemorrhage may occur in some patients due to sudden lowering of intraocular pressure. Corneal scarring. It is usually end result of healed corneal ulcer. Corneal scarring leads to permanent visual impairment ranging from slight blurring to total blindness depending upon the clinical course of ulcer. Corneal scar noted by nebula, macula, leucoma, ectatic cicatrix, keratosis, other leucoma, antistyphyloma, etc. Management of a case of corneal ulcer. The management include clinical evaluation through history taking, general physical examination, ocular examination, diffuse light examination for gross lesions of lids, conjunctiva cornea, regurgitation, syringing to rule out tracheal sac infection, biomicroscope examination after staining of corneal ulcer with 2% freshly prepared aqueous solution of fluorescent dye or sterilized fluorescent impregnated filter paper. Ulcer area stained as brilliant green, which looks opaque green when seen in blue filter. Note site, size, shape, depth, floor, vascularization of corneal ulcer. On biomicroscope, also note presence of carotid precipitate in back of cornea, depth, contents of anterior chamber, color and pattern of iris, condition of crystalline lens. Routine laboratory investigations: hemoglobin, TLC, DLC, ESR, blood sugar, etc. Microbiological investigation. These include studies to confirm the identical cause of the bacteria. Material for such investigation obtained scraping the base and margin of corneal ulcer under local anesthesia using 2% xylocaine or preferentially paracaine, which has been modified Kimura spatula. Material obtained used for following investigation: gram Gemsa stain smears for possible identify infected organism, 10% KOH wet preparation, calculate for white. Preparation is viewed under fluorescent mechanism for fungal filaments, which appear bright apple green. Culture on blood agar medium for aerobic organism. Culture on Sabord dextrous agar medium for fungi. Treatment specific, non-specific, supportive physical and general measures. Specific include topical antibiotics. Initial therapy should be with combined therapy to cover both gram-positive, gram-negative organism. 45 cephalosporin, 45 tobramycin, 5%, 1.3%, or freshly prepared 45 vancomycin, 5%, that is 50 gram per ml, and one of the commercial oil fluoroquinolones, eye drops, ciprofloxacin, ofloxacin, gatifloxacin, moxifloxacin. Frequency of instillation. Chosen 2 drugs should be instilled alternately as below: every 5 minutes for 30 minutes, every 15 minutes or 2 hours, 1 hour round check for 48 hours, 2 hours during the day, and 4 hours at night. Healing is ensured, then 4 to 6 hours till healing occurs. Subsequent therapy, there is no need to change initial antibody if the response is good. However, if the response is poor, immediately change the antibodies as per culture and sensitivity report. Systemic antibiotics. Systemic antibiotics are usually not required. However, cephalosporin and an aminoglycans or oral ciprofloxacin may be given in fulminating cases with perforation or when sclera is involved. Non-specific treatment. Cycloblegic drugs, preferably 1% atropine eye ointment or drops should be used to reduce pain from ciliary spasm and to prevent formation of posterior synechiae from Secondary iridocyclitis. Atropine also increases the blood supply to anterior via by relieving pressure on anterior ciliary arteries. Brings more antibodies in the aqueous humor. Atropine uses. It also reduces exudation by decreased hyperemia. Other cyclopathy which can be used homotropin ointments. Systemic analgesics, vitamins, ABC complex help in early healing. Physical and general measures, hot fermentation, dark goggles, rest, good diet, fresh air, etc. Treatment of non-healing corneal ulcer. If the ulcer progresses despite the above therapy, the following additional measures should be taken. Removal of any known cause of non-healing ulcer. A thorough search for already missed causes not allowing healing should be made. Common cause of non-healing ulcers are local causes, in recent congregations, Mr. Cilia, impact of foreign body, dacrocystitis, inadequate therapy, wrong diagnosis, lack of ophthalmos, excessive vascularization of ulcer, systemic cause, diabetes mellitus, severe anemia, malnutrition, chronic debilitating disease, patients on systemic steroids. Mechanical debridement of ulcer to remove necrosed materials by scraping floor of ulcer with a spatula under local anesthesia may hasten healing. Cauterization may consider in non-respondent cases. It performed with pure carbolic acid or 10 to 10% trichloroacetic acid. Bandage soft contactants, peritomy, severing of perilimbal conjunctival vessels may be performed when excessive corneal vascularization is hindering healing. Treatment of impending perforation. The following additional measures may help to prevent perforation and its complication. No strain, pressure bandage, to give some external support. Lowering of intraocular pressure by simultaneous use of acetazolamide 250 mg QID, orally intravenous menthol, dripstat, oral glycerol twice a day, 0.5% molar eye drops twice a day. Even paracentesis with slow evacuation of aqueous from anterior chamber may be performed if required. Tissue adhesive glue as cyanoacrylate is helpful in preventing perforation. Bandage soft contact lens may also be used. Congenital flap. Corneal may be covered completely or partly by congenital flap to give support to weak tissue. Amniotic membrane transplantation may also be considered as an option. Penetrating the therapeutic arthroplasty may be undertaken in suitable cases when available. Treatment of perforated corneal ulcer. Best is to prevent perforation. However, if perforation has occurred, immediate measures should be taken to restore integrity of perforated cornea. Depending upon the size of perforation availability, measures like use of tissue adhesive glues covering with congenital flap, use of bandage, soft contact lens, or therapeutic arthroplasty should be undertaken. Marginal lateral ulcer. Marginal lateral ulcer is thought to be caused by hypersensitivity reaction to staphylococcus toxin. It occurs in association with chronic staphylococcus blepharoconjunctivitis. Moraxella hemophilus are also known to cause such ulcers. Clinical feature: patient usually present with mild ocular irritation, pain, photophobia, watering. Ulcer is shallow. Vascularization recurrence are very common. Treatment: short course of topical corticosteroid drops along with adequate antibiotic therapy often heals the condition. Mycotic caused by fungus, Aspergillus fusarium, Alternaria, Cephalosporium Carvularia, yeast, Candida cryptococcus, dimorphic, Histoplasma coccidiosis, blastomycosis, fungi commonly associated with mycotic ulcer, Aspergillus, most common Candida fusarium. Mode of infection: injury by vegetative material such as crop leaf, branch of trees, injury by animal tail is another mode of infection. Secondary fungal ulcers are common in patients with or immunosuppressed systemically or locally. Role of antibiotic steroids. Antibiotics disturb the symbiosis between bacteria and fungi, and the steroids make fungi facultative to pathogens. Clinical features: symptoms similar to corneal ulcer, bacterial corneal ulcer. Signs: corneal ulcer is dry looking, greyish white, elevated rolled out margins. Delicate feathery finger-like extension, sterile immune ring, multiple small satellite lesions, usually big hypopyon is present even if ulcer is very small. Endothelium. Endothelial plaque composed of fibrin leukocytes may locate under stromal lesion. Perforation in mycoid ulcer is rare but can occur. Corneal vascularization is conspicuously absent in pure mycoid ulcer. Diagnosis. Typical clinical manifestation associated with history of injury by vegetative material or highly suspicious of mycotic corneal ulcer. Chronic ulcer worsening in spite of most efficient treatment. Laboratory investigation required for confirmation include examination of wet KOH, calcofluorite, gram gensa, sabotextras, methods of sample cutting, scrapings, anti-sample paracentesis, corneal biopsy. Confocal microscopic examination of cornea is reported to identify actual fungi. Polymerase chain reaction also being recommended for its rapid results. Treatment: topical antifungal, natamycin, amphotericin, fluconazole, miconazole, voriconazole, nystatin, ointment 5 days. Effective against candida. Intracameral, intracorneal administration of voriconazole. Systemic antifungal drugs may require for severe case of deeper fungal keratitis. Tablet fluconazole, ketoconazole, voriconazole may be given for 2 to 3 weeks. Non-specific infection, therapeutic penetrating keratoplasty, viral corneal ulcer. Common viral corneal has become much greater, especially because of the role of antibiotics in eliminating pathogenic bacterial flora. Most of viruses tend to affect the epithelium of both congenital cornea, since the typical viral lesions constitute the viral keratoconjunctivitis. Common viruses are herpes zoster, adenovirus, etc. Herpes simplex keratitis. Ocular infection with herpes simplex virus are extremely common, constitute herpetic conjunctivitis and iritis. Herpes simplex virus is a DNA virus. It is only natural host is man. Basically, HSV is epitheliotropic but may become neurotropic. According to different clinical immunological properties, HSV are of two types: HSV1, HSV2. HSV2 also been reported to cause ocular lesions. 1. HSV1, it is acquired by kissing or coming in close contact with the patient suffering from herpes labials. HSV2 is transmitted to eyes of neonates through infected genitalia of the mother. Ocular lesions of herpes simplex. Primary lesions, skin lesions, congenital acute follicular conjunctivitis, cornea, fine epithelial punctate keratitis, coarse epithelial punctate keratitis, dendritic ulcer, recurrent herpes, active epithelial keratitis, punctate epithelial keratitis, dendritic ulcer, geographic ulcer, stromal keratitis, disciform keratitis, diffuse stromal necrotic keratitis, tropical keratitis, herpes iridocyclitis. Primary ocular keratitis. Primary ocular keratitis involves a non-immune person. It typically occurs in children of 6 months till 5 years of age. In teenage, initially infection occurs by direct contact of mucous membrane with infected secretion. Clinical features. Systemic features include mild fever, malaise, non-suppurative lymphadenopathy. Rarely severe morbidity can result from multi-system failure. Skin lesions in face, lips, lids, periodontal, lid margin, etc. Ocular lesion, acute follicular conjunctivitis. The regional lymphadenopathy is usual and sometimes the only manifestation of primary infection. Keratitis. Cornea is involved in about 50% of cases. Keratitis can occur as a coarse punctate or diffuse branching with keratitis. Recurrent ocular herpes. The virus which lies dormant in trigeminal ganglion periodically reactivates and replicates. The reactive virus is enveloped virus in enveloped infection form travels down along the trigeminal nerve to cause recurrent infection. Recurrent herpetic ocular infection is not associated with the systemic features and typically is a unilateral disease. Predisposing stimuli which trigger an attack of herpes keratitis include fever such as malaria, flu, exposed to ultraviruses, general ill health, emotional or physical exhaustion, mild trauma, menstrual stress following administration of topical or systemic steroids. Epithelial keratitis. Symptoms of epithelial HSV keratitis include redness, pain, photophobia, tearing, decreased vision. Signs. 3 signs. Punctate epithelial keratitis 6.9 AB. Punctate keratitis. The lesions of fine or coarse perforation punctate lesions. Dendritic ulcer 6.9 CND. Dendritic ulcer. Its typical lesions occur in epithelial keratitis. The ulcer is of irregular zigzag linear branching shape. Branches are generally knobbed at ends. Floor of the ulcer stains with fluorescein and virus laden cells at margin take up rose bengal. Floor and virus laden cells take rose bengal. Geographical ulcer. Sometimes the branches of dendritic ulcer enlarge and coalesce to form a large epithelial ulcer with geographical or amoeboid configuration. Hence the name. The branches of this dendritic ulcer coalesce and form the geographical ulcer. Treatment. Specific treatment: antiviral drugs. Acycloguanidine, acyclovir 3% ointment 5 times a day, 14 to 21 days. It penetrates intact corneal epithelium stroma, achieving therapeutic levels in aqueous humor. Ganciclovir, it's a gel, and trifluorothiamidine 1% of adenine arabinose, vidarabine 3% ointment, mechanical debridement. Systemic antiviral drugs for a period of 10 to 21 days. Acyclovir, famciclovir, valacyclovir, 400 to 50 and 500. Non-specific supportive therapy. And this one is disciform keratitis. Stromal keratitis, disciform keratitis. It occurs due to delayed hypersensitivity reaction to HSV antigen. Primarily, there occurs endothelitis. Endothelial damage results in disciform corneal stromal edema due to imbibition of aqueous humor. Symptoms: photophobia, mild to moderate ocular discomfort, reduction in visual activity. Signs: focal disc-shaped patch of stromal edema without necrosis, folds in decimal membrane, keratitic precipitates around the area of stromal edema, ring of stromal infiltrate, Wesley immune ring. Corneal sensations are diminished. Intraocular pressure may be raised despite only mild anti-uveitis due to trabeculitis. Important note: treatment consists of diluted steroid eye drops instilled 4 to 5 times a day with an antiviral cover, acyclovir, twice a day. Steroids should be tapered over a period of several weeks. When disciform keratitis is present with the infected epithelial ulcer, antiviral drugs should be started with 5 to 7 days before the steroids. Non-specific and supportive treatment. Stromal necrotic keratitis. It is a type of interstitial keratitis caused by active viral invasion. Pain, photophobia, and redness are common symptoms. Signs: corneal lesions include necrotic blotchy, mild iritis, stroma escalation. Treatment: systemic antiviral drugs. Keratoplasty should be referred until eye has been quiet. Metaherpetic keratitis is not an active viral but is mechanical healing problem due to persistent defect in basement membrane of corneal epithelium. Clinical feature: presence of indolent linear ovoid epithelial detect. Treatment: promote healing by use of lubricant, artificial tear, methyl cellulose, etc. Herpes zoster ophthalmicus. Herpes zoster ophthalmicus is an acute infection of Gazerian ganglion of fifth cranial nerve by varicella zoster virus. It consists of approximately 10% of all cases of herpes zoster. Occurs more common in immunocompromised individual. Etiology: varicella zoster. It is a DNA vector produces astrophilic intranuclear inclusion volumes. It is neurotropic in nature. Pathogen: infection is contracted in childhood which manifests as chickenpox. Child develops immunity. The virus then remains dormant in the sensory ganglion of trigeminal nerve. It is thought that usually in elder people with depressed cellular immunity, the virus reactivates and replicates and travels down along one or more of the branches of ophthalmic division of fifth nerve to produce cutaneous and ocular lesions. Frontal nerve is more in clinical vision. Frontal nerve is more frequently affected than lacrimal and isociliary nerves in herpes zoster ophthalmicus. Ocular complications occur in about 50% of cases. Herpes zoster ophthalmicus. Hutchinson rules, which implies that ocular involvement is frequent if the side or tip of the nose presents vesicles, is useful but not infallible. Lesions are strictly limited to one side of midline of the head. Clinical phases of acute phase lesions, chronic phase lesions, relapsing phase lesions. Acute phase lesion. General features: cutaneous ocular lesion. General features: the onset of illness sudden with fever, malaise, severe neurologic pain along the course of infection. The distribution of pain is so characteristic of zoster that is it usually arouses suspicion of nature of the disease before appearance of vesicle. Cutaneous lesions in the area of distribution of involved nerve appear usually after 3 to 4 days of the onset of disease. To begin with, skin of the lids and other affected areas become red and edematous following followed by vesicle formation. In the course of time, vesicles are converted into pustules, which subsequently burst to become crusting ulcers. When crusts are shed, permanent pitted scars are left. The active eruptive phase lasts for about 3 weeks. Main symptom is severe neurologic pain, which usually diminishes with subsidence of eruptive phase. Ocular lesion. Ocular complications usually appear at the subsidence of skin eruption and may present as combination of 2 or more following lesions. Conjunctivitis is one of the most common complications of herpes zoster. It may occur as mucopurulent conjunctivitis, petechial hemorrhage, or acute follicular conjunctivitis with regional lymphadenopathy. Sometimes severe necrotizing membrane inflammation may be seen. Zoster keratitis occur in 40% of all patients. It may occur in several forms. Zoster keratitis, epithelial keratitis. To begin with, there occurs fine coarse punctate epithelial keratitis. Fine coarse epithelial keratitis. It is followed by microdentic epithelial ulcers, which, unlike dendritic ulcer of herpes, are usually peripheral stellate rather than exactly dendritic in shape. Nummular, it is microdentic. Nummular characterized by anterior stromal infiltration is seen in about 1/3 number of total cases. Typically occurs as a multiple tiny glandular deposits surrounded by halo of stromal gas. Nummular scars are left behind. Disciform keratitis. It occurs in about 50% of cases and is also preceded by nummular keratitis. Episcleritis and scleritis occur in about 1/2 of the cases. These are usually appear at the onset of rash but are frequently concealed by overlying conjunctivitis. Iridocyclitis is of frequent occurrence and may or may not be associated with keratitis. There may be associated with hypopenia and hypemia. Acute retinal necrosis may occur in some cases. Secondary glaucoma, it may occur due to trabeculitis in early stages, cynical angle closure in late stages. Anterior segment necrosis, thighs bulbae may occur rarely as a result of zoster vasculitis. Associated neurologic complications, motor nerve palsy, optic neuritis, encephalitis, chronic phase lesions. Chronic phase lesions are basically sequel of acute phase which may persist up to 10 years. Post-herpetic neuralgia refers to persistence of pain after subsidence of eruptive phase of zoster. Pain is mild to moderate in intensity, worsens at night and is aggravated by touch and heat. But sometimes it may persist for years, little diminution of intensity. Some anesthesia of affected skin, which when associated with continued post-therapy in neurology, is called anesthesia dolorosa. Lid lesions, which occur as sequelae of scarring, include ptosis, trichiasis, erythropen, notching, etc. Conjunctival lesions include chronic mucus secreting conjunctivitis. Corneal lesions are as well neuroparalytic ulceration, exposed keratitis, mucous plaque keratitis, etc. Sclerating and uveitis may persist in chronic form. Relapsing phase lesions. Relapsing phase lesions which may recur even after 10 years of acute phase include nummular keratitis, mucous plaque keratitis, episcleritis, scleritis, secondary glaucoma. Treatment. Therapeutic approach to herpes zoster ophthalmos should be vigorous and aimed at preventing severe devastating ocular complications and promoting rapid healing of skin lesions without the formation of massive crusts which result in scarring of nerves. Systemic therapy for herpes zoster. Oral antiviral drugs. These significantly decrease pain, curtail vesiculation, stop viral progression, reduce incidence as well as severity of keratitis and iritis. It has no effect on post-herpetic neuralgia. Acyclovir, Vialis acyclovir, analgesics should be given to reduce pain and in first 2 weeks of life, 2 weeks of attack. Systemic steroids, they appear to inhibit development of post-herpetic neuralgia when given in high doses. However, the risk of high doses of steroids in elders should be taken in consideration. Cimetidine 300 mg QD started 40 to 78 hours to reduce pain, pruritus in acute zoster, presumably histamine blockade. Amitriptyline should be used to relieve the accompanying depression in acute phase. Local therapy for skin lesion, antibiotic therapy, no calamine lotion. Cool zinc calamine application is advocated earlier but avoided as promote crust formation, zinc crust. Local therapy for ocular zoster keratitis, iridocyclitis, topical steroid eye drops, cycloplegics, cyclopentolate, topical acyclovir 3% ointment, 3% eye ointment. To prevent secondary infection, topical antibiotics are used for secondary glaucoma. 0.5% timolol, 0.5% beta-oxalol, acetazolamide 250 mg QAD for mucous plaques. Topical mucolytics, acetylcysteine for persistent epithelial defects, lubricating artificial teardrops, bandage soft conductance, surgical lateral dorsography, amniotic membrane transplantation, tissue adhesive, keratoplasty, etc. Protozoal keratitis, Acanthamoeba keratitis, etiology Acanthamoeba castellini, mode of infection contact lens virus, non-contact lens, mild trauma, saltwater diving, wind blowing contamination, opportunistic infection Acanthamoeba and also occurs opportunistic infection. Symptoms vary from asymptomatic to foreign body sensation, mild pain, severe pain, etc. Signs Acanthamoeba keratitis evolves several months as a gradual worsening keratitis evolves over several months. Reported lesions of academic keratitis are epithelial lesions include epithelial roughening, epithelial ridges, pseudodendritis, epithelial subepithelial, curvilineal opacity, stromal lesion, radial keratoneuritis, about in 50% cases, patchy satellite stromal infiltrates, ring infiltrates, central or paracentral with overlaying epithelial defects, ring abscess, limbal and scleral lesions, limbitis, scleritis, academic keratitis, radial keratoneuritis, ring infiltrate, ring abscess. Differential in viral keratitis, fungal keratitis, suppurative keratitis, fungal it is associated with hypopyon, suppurative misdiagnosis in stage of stromal necrosis. Clinical diagnosis difficult, usually made by exclusion with strong clinical suspicion. Confocal microscopy, laboratory diagnosis, potassium hydroxide mount, calculus for white stain to rule out by fungal. Lactophenol, cotton blue, culture on non-nutritional polymerase chain reaction, corneal biopsy. Treatment non-specific, specific, topical anti-amoebic diamidase, bigonides, aminoglycosides acids, multiple drug therapy, bromocric examidine, chlorohexidine, neomycin, paromycin. Frequency of installation hardly for a week, then taper slowly over 3 to 4 months for epithelial lesion, 6 to 12 months for stromal lesion. Oral ketoconazole 200 mg BED or itraconazole 100 mg BED. Long-term prophylactic therapy with PHMB. Penetrating keratoplasty, allergic, flectral or vernal atopic, tropic corneal ulcer. We'll see in the second part of the video. Thank you.